Good morning, everyone. Today, myself, Jess, and Tom will be presenting to you our poster. We did our project on the potential significance of vitamin D levels in COVID 19 positive patients. So let's get started. As you may know, the new SARS CoV 2 virus that causes COVID 19 in humans has resulted in over 111 million identified cases and nearly 2.5 million deaths globally to date. Of that, 80 to 85% of cases are asymptomatic and can be resolved by having the individual self isolate, no medical intervention required. However, 7.7% still require hospitalization. That's over 8.5 million cases requiring extensive medical help so far. Data has shown that 90% of patients being hospitalized have underlying medical conditions such as hypertension, obesity, cardiovascular disease, and/or diabetes. These factors are known to compromise the immune system and decrease its ability to fight off infection. The elderly are more susceptible to these factors and disproportionately affected by COVID 19. Another trend observed in COVID 19 hospitalizations is that African Americans are 2 times more likely to die of the virus compared to Caucasian Americans. These medical conditions and African ethnicity are contributing factors to vitamin D deficiency. Another factor to consider when looking at vitamin D in COVID 19 is location. Mortality rates for COVID 19 vary between countries, but are lower in the southern than northern hemisphere. A possible hypothesis to explain this is the difference in sunlight exposure. Lack of sunlight exposure in the winter and northern hemisphere is linked to a more widespread vitamin D deficiency in the population. Vitamin D can be obtained externally when the sunlight hits the skin or internally when ingested in our food and drink. Deficiency is developed over time as people have limited sunlight exposure or inadequate diet. Vitamin D is most often measured based on serum levels of 25-OHD, which is a form of the vitamin that is converted at the liver. An advantage to this measurement is it reflects both the internal and external methods of vitamin D. Serum levels of 25-OHD below 30 nanomoles per liter are consistent with a diagnosis of vitamin D deficiency. Vitamin D has been established as having a role in both the innate and adaptive immune response. In the innate system, vitamin D stimulates the expression of antimicrobial peptides, which are important in maintaining a tight gap junction in epithelial cells. Damaging the integrity of this barrier is a known attack mechanism for viruses and increases the risk of infection. The SARS-CoV-2 virus binds to lung cells, activating the innate and adaptive immune system. These systems release cytokines, which dysregulate the immune system response and can commonly cause ARDS. The SARS viruses are known to hyperactivate the cytotoxic T cells and impact the complex signaling for T and B lymphocytes and natural killer cells to function, therefore decreasing their response and impact on the virus. For our research, we set out to determine whether there is a correlation between serum vitamin D levels and COVID-19 outcomes, and if so, if vitamin D supplementation could be proactive in COVID-19 outcomes and severity management.
So in terms of our methodology, it's real simple. We just search literature, journal articles, and review papers on the topic of COVID-19 in combination with vitamin D and their outcomes. So this was between January 22 and March 25, 2021. The search was done by using databases like Conestoga Library and Google Scholar. So the very first paper that we look at, it was by Lull et al. 2020. In this paper, they just looked at vitamin D deficiency, or VDD, and COVID-19 patients. They specifically defined VDD as serum 25-OHD levels below 30 nanograms per milliliter tin. Out of the 20 COVID-19 patients, 13 of them needed ICU admission. 11 of the 13 had VDD, or 84.6%. Other things worth noting about these patients, when 100% of these patients were below 75 years of age, so they were not relatively old at all. 7 out of the 11 patients, they actually had critically low vitamin D levels, which was just 20 nanograms per milliliter. 3 of the patients actually had astronomically low vitamin D levels, which was about 10 nanograms per milliliter or less. Out of the 7 non-ICU COVID-19 patients, 4 of them had VDD as well, and of the 20, none of them had stroke, myocardial infarction, or pulmonary embolus. So the next paper that we looked at was by Panagiotto et al. 2020. This was kind of similar to Lal et al. 2020, except they looked at 134 COVID-19 Canadian inpatients instead of 20, right? And they found that most of these COVID-19 inpatients, or 66.4% of them, had vitamin D deficiency, which they defined as 25 to 50 nanomoles per liter. 50 of these inpatients, or 34%, were simply deficient, while 29, or 21.6%, had severe deficiency. What's also interesting is that they found a significant association with COVID-19 status and hypertension and obesity. Also, of the patients that were in the ICU, they were on average younger, but they still exhibited a significantly higher prevalence of VDD. So, we also looked at a paper by Diavolo et al. 2020. I know what you're thinking. This paper already looks pretty similar to the last 2 papers that we looked at. The reason why I like this paper a little bit is because they look at factors outside of just, COVID-19 status and vitamin D levels. I'll get to that in a second. But to summarize their paper, this was done in Switzerland, They looked at 107 patients in 2020, and they specifically looked at patients who went for a swab for COVID-19 and vitamin D levels. Also, in 2020, they looked at 1,377 results of swabs for vitamin D levels. We're kind of running short on time, though, so I'm not going to discuss that in too much detail. But to summarize their results, they found that vitamin D levels were on average lower in COVID-19 patients than, patients that did not have COVID-19, which shouldn't be too much of a surprise, to be honest, at this point. So the mean was about 11.1 nanograms per milliliter if you were COVID-19 positive versus 24.6 nanograms per milliliter if you were negative. And like I said, they looked at factors outside of just COVID-19 status and vitamin D. For example, they looked at gender as well. And what's real interesting is that when you account for gender, COVID-19 status and vitamin D levels, they stop becoming significant. So it doesn't matter if you're COVID positive or negative, right? Your vitamin D levels are not significantly different from each other if, you account for gender. And you can see the p-values here, right? They're well above 0.05. And it's kind of similar to if you look at age as well, right? If you're below 70 years of age, your COVID-19 status stops becoming a significant, or at least it stops having a significant impact on your vitamin D levels. So it doesn't matter if you're COVID positive or negative. Your vitamin D levels are not going to be significantly different from each other if you're below 70. It only makes a difference if you're beyond 70 years of age. That is, you can look at their stats, right? So if you're beyond 70 years of age and you're COVID positive, your average vitamin D levels was about 9.3 nanograms per milliliter, while if you were negative, they were about 23.1 nanograms per milliliter. And the p-value right there is 0.037, so that's well below 0.05. The next paper that we look at is by Brayman, 2020. Here he looks at, just higher latitude countries and their relationship with vitamin D and COVID-19. So he found that higher latitudes are correlated with vitamin D deficiencies. So, and his explanation was that these higher latitudes have higher elevations of the sun and the sky, which increases the ratio of UV to visible light. And, these countries typically have higher levels of skin coverage by clothing due to like their temperature. So, regardless, he found that altitude bands with the highest death rates were centered around 40 degrees north, which is pretty high, right? And they include China, Iran, and Italy. Basically, the most impacted countries with a death rate of nearly 5 per thousand, right? And this was 10 to 15 times the reported death rate of any nation in the southern hemisphere except Indonesia. So, despite being only 10% of the total cases, these lower latitude countries only account for about 1% of the reported deaths. So, the next paper that we look at is by Razy, Esterberg et al., 2020. And this paper was kind of a response to the mounting evidence suggesting there is a disproportionate effect of COVID-19 in Black, Asian, and minority ethnic populations. We're just going to shorten that to BAM. So, even in the first paper that we looked at, Lull et al., 2020, they hypothesized that the increased VDD rates of African Americans was related to their disproportionate COVID-19 deaths. And, VDD affects about 80 to 90% of African Americans, right? And the example that Lull et al. 2020 gave was that African Americans make up about 70% of the Louisiana COVID-19 deaths, despite being only 32% of the population. So, like I said, Razy Esterberg was kind of a response to this growing concern about BAM and COVID-19 relationships. So their paper, they looked at a lot of aspects, right? Not just vitamin D levels. To summarize it, though, they looked at 4,510 participants of varying ethnicities. And they looked at many aspects, including, vitamin D levels, cardiometabolic factors, material deprivation, housing conditions, socialization, etc. And they found that BAM populations had vitamin D levels that were on average lower than white ethnicities. They also found that BAM populations were, had greater odds for COVID-19, right? But they failed to find a significant association between vitamin D levels and COVID-19 positivity in BAM populations. They actually go one step farther in the title of their paper, right? They say that vitamin D levels do not explain the variance of COVID-19 positivity in BAM populations. So, that concludes our results.
At the beginning of this presentation, my co-presenter Andy spoke about how vitamin D is important for modulating the innate and adaptive immune system. And with low levels, the patient has an inability to produce proper levels of macrophages and lymphocytes, leading them to not be able to fight off a virus properly. She also spoke about how vitamin D is responsible for stimulating the expression of antimicrobial peptides known as defensins. Defensins, again, are responsible for maintaining tight gap junctions, and when the defense is lowered, a person is at greater risk for developing infections and pulmonary complications. But looking deeper at vitamin D in the body, when a patient has low levels of vitamin D serum, they're at an increased risk of inflammation. Vitamin D is used in the adaptive immune response to suppress the type 1 T helper cells, which in turn decreases the production of the pro-inflammatory cytokines. It also promotes the production of type 2 T helper cells, which are anti-inflammatory cytokines, which indirectly suppresses type 1 and diverts their production to type 2. Now, why is this important? Well, with low levels of vitamin D, the body is unable to produce type 2 T helper cells, and therefore is in an overproduction of type 1 cells. Pro-inflammatory cytokines are responsible for creating a medical phenomenon known as a cytokine storm. A cytokine storm is similar to an autoimmune disease where the body will start to attack its own cells and tissue, leading to an impaired immune response and a higher risk of COVID 19 fatalities. Numerous COVID 19 cases actually start out as mild and then tend to become fatal due to an increased level of cytokines. So, patients with low levels of vitamin D tend to already be at a disadvantage when contracting COVID 19, as their immune response will be impaired and the risk of cytokine storm is elevated. Although there has not been enough solid research done on the correlation between vitamin D levels and the severity of COVID 19, I thought it was a valid piece for discussion. There have been solid predictions made, with evidence science and healthcare professionals have already discovered. For example, darker skin tones tend to absorb vitamin D at a slower rate, making African Americans the most susceptible population to being vitamin D deficient under normal circumstances. If there is a correlation between vitamin D deficiencies and COVID 19, it would help explain why the level of severity of COVID 19 in the 60 and older African American population is so high. Combined with their darker skin tone, their age would negatively impact their body's ability to defend against the COVID 19 virus. Looking at the homeless population, the homeless population has been one of the largest populations to contract COVID 19, but has also been one of the largest populations to have non asymptomatic patients. The homeless population tend to spend more time outdoors in the daylight, therefore, are exposed to more UVB, which is a natural way the body receives vitamin D. The hypothesis can be formed that the more UVB a person is exposed to, the higher the vitamin D levels. And in that case, it could explain why the homeless population has been able to reduce the severity of their COVID 19 cases. Vitamin D levels have also been recorded in various countries, with results finding that in countries where COVID 19 has been more severe, like Italy, Spain, and Greece, there is a higher associated vitamin D deficiency population. Where countries with lower case counts, like Norway or Denmark, they tend to have a smaller population who are vitamin D deficient. This tends to be a cultural and diet factor, where the vitamin D in our regions tends to be from supplements and diets high in vitamin D. Speaking of differences between countries, Andy mentioned this earlier, but there has been a ton of significant difference in the number of severe cases of COVID 19 between the two hemispheres. The southern hemisphere is recording lower numbers, where the northern hemisphere is finding a higher case count. There are numerous differences between the two hemispheres, but one hypothesis is the amount of sunlight the southern hemisphere gets is drastically more than the northern half. Again, this could be an area of research to learn more about the effects of a person's vitamin D levels affecting their outcome with COVID 19. In conclusion, after reviewing numerous studies, research papers, and reviews, it can be concluded that the preliminary thought is that there will be a link between vitamin D levels and COVID 19. But of course, more research is needed to solidify that hypothesis. From our review findings, the suggestion for further studies would also include trials of treating mild cases of COVID 19 with a vitamin D supplement to see if alleviating the deficiency early can help overcome the virus or prevent the virus from becoming fatal. This can also branch out into research of if vitamin D can be a preventive supplement if taken before a host becomes infected. Lastly, a thought for everybody. In Canada, it is recommended that the average person has anywhere from 600 to 800 international units of vitamin D a day. But due to our diet, location, and lifestyle, at least 30% of our population is vitamin D deficient, and that number nearly doubles during the winter months. The Canadian Nutrition Society recommends that all Canadians take a vitamin D supplement of 400 international units a day, as our intake is nowhere near our daily limit and therefore would cause no adverse side effects. Again, this is just our poster, just for everybody to reference it now that you've heard our presentation. And to sum it up, here's our list of our references. I hope everybody has a great Friday.